Hello, and sorry for the long time since the last episode. The period is quite busy, so we tried to provide you a new episode, even if it's a little short, and we are working now for the future one. Please advise if you need something in ESD, some precise topic, so we can have more ideas of the future episode. Today, we will present a complete case of a technique which is similar to ESD, but which has a particular strategy, which is the submucosal tunneling for stromal tumor, which is called commonly the STER procedure. So first, we will talk about the submucosal tumors. They are gastrointestinal stromal tumors. It means that these lesions are mesenchymal tumor coming usually from the muscula, wrist, and from the muscle. Commonly, the most frequent one comes from the muscularis propria, but some of them are coming from the muscularis mucosa, which is completely different for the resection. So these are examples of this kind of lesion histologically. And finally, we have different kind of resections. EUS is sometimes useful to predict the layer where the lesion is coming from. Is it the muscularis mucosa with submucosa under, like on the left, where ESD is a technique which is possible because you don't have to cut the muscle. Is it a lesion coming from the muscularis propria? And in this case, perforation is unavoidable, and you should discuss about different strategies. Strategy of non-exposed perforation into a tunnel. It is the STER. We will present this technique today. Or some physicians prefer to do an exposed technique with a complete perforation, which is closed after the resection. And there is a last technique, which is a laparoscopic endoscopic cooperative resection called NEWS, coming from Osamu Goto in Tokyo, which combine an approach by surgeon on the exterior wall of the stomach, doing an incision on the two sides, all around the lesion. Then they put a sponge and they do a kind of suture on the exterior wall of the stomach, and the endoscopist has only to cut mucosa and submucosa to half the lesion and remove it by the mouth. The limitation is the size of the lesion because above 3.5 or 4 centimeter, it is sometimes difficult to retrieve the lesion through the cardia. So I think the window for endoscopy technique are the small gastrointestinal stromal tumor of less than 4 centimeters that seems accessible to endoscopy. It means that you are able to reach it with the scope, which is not always the case. For example, for the top of the fundus, sometimes it can be really technically challenging. So this is the case under US. It's a 1 centimeter lesion, which is hypoechoic, developed exactly on the muscular layer. And in this case, it is almost half and half. It's not so exophytic, not so visible into the light of the stomach. We have something which is really centered on the muscular layer. We are around 4 centimeters above the cardia on the posterior wall, and the patient is on the back on supine position. So I would say it's the best case for submucosal tunneling endoscopic resection because the scope is on the good axis, the lesion is almost in the axis of the cardia, so probably it seems to be the good case to demonstrate the technique with a relatively short complete case to discuss for this example. So I will present you here the complete case of the resection by STER. The movie was not working at the beginning, so unfortunately we missed the initial incision, despite the fact that it is an important point, because we should really precisely target the axis of the channel. I will show you in few minutes that I go outside the channel very frequently. And I usually do small marking on the axis of the tunnel to reach the lesion, because sometimes once the injection is done, the lesion disappear completely, and it's sometimes difficult to be sure of the axis of the tunnel. So unfortunately, in this case, we touch in the left edge of our incision a small vessel. It was a little difficult to control because the exposure was not good. So I tried to go under to do a little more my tunnel in order to be more stable in this area. And then by removing the scope slowly, I could see, thanks to RDI, the bleeding point. And finally, we could obtain hemostasis a little blindly in the angle, thanks to the fact that we saw it by going a little deeper in the channel. So it's an important point probably. When you have a bleeding that comes from a blind area, try to do a little more tunneling or of dissection or of incision to open a little more the space in order to at least see where the bleeding comes from, and then later to be able to coagulate with exposure if it's possible, blindly if unfortunately it's almost impossible to see the point, because the edge of your incision is always falling down. So once this bleeding was controlled, we could really begin the tunneling. And this tunneling should be really cautious, because if you do it too large, it's sometimes difficult to reach the lesion. In the fundus, for example, sometimes it's really difficult to keep the access to the lesion. So once again, please lose time to control. The lesion is here. So this is here, so I could do small marking to be sure I'm going in the good axis, because once I will reach the lesion, it will be really difficult to see it from the lumen size, because the injection will make the relief, the shape disappear. So it's very important to control the bleeding axis and to do dots at the beginning to precisely describe the position of the lesion, and if possible to precise the direction of your tunnel while you are progressing in submucosa. I think that we will probably see soon something with yellow, which is in fact not yellow, but in the submucosa, the first picture of the lesion that appears here, you can see it. So we are front of the lesion. We know that now the direction of the channel is very good, and we will try to dissect in the two sides of the lesion. You will see it more clearly soon. So it's very important after to avoid any damage on the submucosal lesion in order to avoid a non-complete resection or a damage of the capsula of the lesion that makes the resection non-complete, and that oblige to maintain a follow-up. Also, this stromal tumor is a tumor with a very low risk in Mitinen classification. So it's probably something we should consider. If we can have a really complete resection with no contact on the lesion edge, it's better, because we will probably completely forget this lesion, avoid any follow-up after, if the resection is without any damage. So one of the thing we try to do is to keep some margin, some submucosa around the lesion, so we don't go very close to the lesion in order to keep a small edge, a small margin uh, for the pathologist. And after, I prefer to do the mucosal side first. So I make a space a little larger that makes me able to go behind the lesion at the anal side and to make the lesion free from the adherence of the submucosa in the anal side. So if you begin to cut the muscle, the time of perforation is longer, the duration of the perforation is longer. So in our strategy, we prefer to begin by the mucosal side. We like to make the lesion completely free from the mucosal adherence. And then we will do the voluntary perforation after, when we have the impression that there is no more remaining submucosal fixation of the lesion on the anal side. So here we turn around, we go behind the lesion, inject again the mucosal space. We see that despite the previous biopsy sample that were done by my colleague before, biopsy that were negative, the pathologist cannot have the diagnosis of a stromal tumor in this case. Um, Despite this, there is no big fibrosis that makes the resection on the mucosal side difficult. So it's almost normal in the stomach. Even if biopsy sample were done, the risk of fibrosis is really relatively low compared to what we are used to in the colon, for example, where the submucosa is probably thinner, and every biopsy sample on the lesion makes the resection more difficult. In this case, we cannot say that fibrosis was preventing anything. So it was quite um, easy to turn around the lesion and remove the mucosal, the submucosal, sorry, fixation. So we make the lesion free. I think even more than in ESD, it's probably better to control the bleeding quickly in order to avoid this kind of coagulation of dark spot that make the ESD less precise, because once again, our goal is to avoid any damage on the lesion in order to be able to have a complete resection and to stop any follow-up for the patient. Um, we know that despite the fact that the risk of the lesion is very low, if we have an incomplete resection, it's difficult to stop any follow-up. So finally, we will increase the cost, the burden, and the environmental burden of the follow-up by doing something relatively frequently to be sure. If the resection is completely complete, we will stop everything and we will let the patient forget this history and then reduce its impact uh, for the economical and environmental burden of the follow-up. So once we have the impression that everything is free, we will go. It means we will do this perforation, cutting the muscle and getting outside the stomach. Fatty tissue is here. The gravity here is probably pushing the lesion on the posterior fat. So the space between the stomach and the fatty tissue is not really clear. And the anesthesiologists were focused on the pressure and the capnia, and finally nothing moved. So despite the fact that the perforation seems complete, probably the free space around the stomach was not totally reached without any gas collection, without any pneumoperitoneum, and therefore without any impact on the ventilation by our anesthesiologist. So I think we should be relatively cautious because a lot of vessels are in this area, relatively big compared to what we are dealing usually in the submucosa. So it's probably important to try to go slow and to avoid any damage on the muscle. In this part of the procedure, clearly, I prefer to have a non-exposed procedure into a tunnel. I know that there is a lot of strategies doing a complete perforation with a pneumoperitoneum without a lot of consequences for the patient, but nevertheless, we are not surgeon in France for doing this kind of procedure, which which is the task of the endoscopists who are gastroenterologists in France. And therefore, we are more confident where when the pneumoperiton is less important and when the area of muscle damage will be covered thanks to the mucosa that has been protected during the procedure. And really, our strategy, when it is feasible, when the tunnel axis is quite easy to do, the first option is clearly the tunneling strategy. There is a limitation of size. We will see that this one is very small, 1 centimeter, but the most difficult part of the procedure will be to get it outside the tunnel. So here we achieve the resection. We cut the last fibers of the muscle. After the lesion is free from anything, but it's still blocked into the entrance of the channel. So I had to repeat this at least I think 8 or 9 times to get the lesion out, despite the fact that it was free from any adherence. I went to control if there is any adherence. I forgot because I was a little surprised that I couldn't get it outside, but in fact, it is free, completely free. There is no more adherence, but every time there was an angle at the entrance of the channel, which makes the extraction, the retrieval of the lesion difficult. So you will see the longest or the most difficult part of the procedure was here, and it takes at least 2 or 3 minutes to get it outside the channel. We will manage finally. The option here was to use the knife at least to push the lip of the entrance. I tried, and if it was not possible, I would have increased the size of my incision to get the lesion outside. I don't like to use snare in this case because I'm always afraid of a damage on the edge, on the capsule of this stromal tumor. Because after the pathologists are not able to say the resection is complete, and it makes our conclusion uncertain. So as much as possible, I try to get it in the cap. We see that it is entering into the cap here on a gastroscope. So the size of the cap is 10.5 millimeters. So the lesion is probably around 1 centimeter. Um, you will see it. I'm sorry for this long exposure and long extraction of lesion, but finally I think we will manage here, or almost. So after this extraction, the procedure is not completely achieved. We still have to close the entrance of the channel, but in this case, it was not too challenging with conventional clip, so no need to use a more advanced technique of closure like suture art, like mantis clip or conventional clips were okay to obtain a complete closure. Is it the good one? I think so. Yeah, probably it's the good one. Ah, no, not again. Sorry. Okay, finally we managed to do it. So we have the lesion here, around a little more than 1 centimeter, 11 or 12 millimeters. And finally, we used conventional clip to obtain the closure. Three clips were necessary to close the entrance of the tunnel, which was, I think, 2 or 3 centimeters above the cardia. Here it's a structure. The patient has also, we just did before a radial incision of the peptic structure. It was the main problem of the patient, and the stromal tumor was discovered by one of our fellow, Raphael, during a procedure to control the esophagitis. So it was really a completely uh, uh, chance discovery of this stromal tumor uh, because of a good examination of the stomach, while the main question was the esophagitis and the stricture. So even if usually it's not the best way to close to use this axis, here it was relatively good and feasible, and you will see that the three clips will obtain a complete closure. Uh, uh, for the purpose of the peptic disease, we will control the patient in few weeks to see if the radial incision was effective, and also to check if there is anything abnormal on the junction, which seems a little irregular. There was no diagnosis for the moment of Barrett's esophagus, so next step will be to control this area. But at least we will have cured this stromal tumor. So here we could get the two edges quite easily with conventional clips. And I used a third clip to obtain a complete closure. There was no damage on the mucosa front of the muscular damage. The patient will receive a PPI during 6 weeks in order to avoid any further damage on the muscular layer. And the pathology was a very low risk stromal tumor without contact on the lesion. It's still difficult for our pathologists to clearly write that it is R0, because to be R0 you need over tissue, a margin of over tissue all around the lesion. And in this case of stromal tumor, it's difficult to have something around the lesion. It's an enucleation, and this enucleation seems complete, but without normal tissue around, it's difficult to really call it an R0 resection. So finally, and technically, precise tumor targeting is important with small marking in the axis of the channel. Precise anticipation of the channel is important, how the scope is going when you push it. And we do a lot of recurrent control of the tunnel axis to be sure we stay in the good axis. Bleeding prevention and treatment of bleeding is important. The lesion delineation is important with large margin. And then, when it is completely free from submucosal adherence, the voluntary perforation should be done quite quickly to avoid a lot of pneumoperitoneum. And once again, we keep large margin on the muscle. The extraction of the lesion is sometimes challenging, but should be done gently to avoid any damage on the lesion. And finally, in conclusion, different techniques of resection exist for GIST. Non-exposed technique are our favorite for the relatively small lesion when the axis of the channel is possible, because it's more elegant than a large perforation to close to our mind. Exposed techniques are also very effective, but with previsible perforation, and therefore you should have a good experience and a lot of devices to obtain a complete closure when we do a large perforation. So you have to master suturing, clip and snare, some closure technique like the Marceau technique we described some few years ago. but it is also very effective and not so dangerous for the patient. I hope this episode was nice and you learned a lot of things. And I hope to see you soon with the episode we are preparing now. And we will try to let less time between this episode and the next one. Thank you very much.